Again, an immediate action, doctor. Once you say that I will be taking your ECG vitals, examiner will give you the reading. So we call it A, B, C, D, E. Okay. Then patient sit up, oxygen you have to settle. If patient having hypoxia, you have to follow the Mona technique. Communication should be accurate. Like say, doctor, examiner giving reading that okay, patient having inferior wall MI. Okay, so you have to say, Mr. Khan, as I'm really sorry to tell you, you are suffering from the condition which we call it inferior wall MI. Means like say you got heart problem, not heart attack, heart problem. Okay, it means your heart is affected because of that issues, that because of narrowing of blood pipes or whatever so on. So you have to explain this problem, okay? And critical time. This is a critical time, Mr. Khan. As you worried that you have to go back to the work, and unfortunately you cannot go. And I'm going to arrange the ambulance services for you, and you have to see that specialist. You have to get admitted in the hospital right now because it is a time bound thing, time critical time. Okay, so you have to ambulance transfer and don't drive. Don't send the patient with the driving. Okay, these are the few things whenever you go through that OSCE exam, if you are going through this for or this checklist, of course, you will not be getting any negative marking over there. And acute severe asthma, doctor, mostly the patient will be having the problem. Doctor, I'm having breathing difficulty, so we have to check patient vital assessment. Okay, work of breathing, ability to talk or not. Means like say I'm going to think patient having severe asthma or mild to moderate asthma, whatever so on. Okay, and we have to ask about for patient's current status. If like say patient is known of a known asthma, then we have to think about um, patient inhaler usage or not. If patient is using inhaler technique, here you have to ask me, I know how you do use the inhaler, how many time you are using. Sometime agenda lies over here, patient is using salbutamol more, but he is not taking the MART properly. Okay, so we call it improper usage. So we have to rule out whether this patient is suffering from this asthma attack because of improper inhaler technique, or patient got new trigger like say new house, new shifting, new exposure, anything. Red flags, doctor. Here, patient will be having silent chest, exhaustion, and confusion. These kind of cases, they are not going to test in the exam. In the exam, they will be testing your ability to know about exercise-induced asthma, that how they got on first day first in my here and in my exam also day first. So they give it exercise-induced asthma and bronchial asthma. Okay, what are the immediate actions are there? For example, if patient comes in an emergency, I have to nebulize the patient. Mr. Khan, I'm going to nebulize you with a salbutamol. If like say if like, it is patient having severe complaint, then you have to add the ipratropium. You have to explain patients, sorry, explain the medication as per the dosage. Okay. If patient having hypoxia, then you have to give the oxygen and sit. You make the patient comfortable position. Sit upright. If you didn't set upright patient and on lying down position, it will be considered as a pitfall of the exam. Okay. And patient having acute exacerbation of asthma, then you have to offer steroids, oral or IV based on the setting. Okay. There will be a setting that you're working in a clinic. There will be a setting that you're working in a shopping mall, whatever, so on. In MRCGP South Asia International, they are not testing in a mall kind of setting. They are testing in you at clinic setting. So you have to offer injectables. And I'm going to call the ambulance for emergency transfer if patient having moderate or severe asthma. Safety nation, don't leave the patient, Mr. Khan. Don't worry about your condition. We are here to help you. And till the ambulance arrive, I'll be there with you. Okay, I'll be repeating your vitals and we'll be checking your PFR and whatever the escalation that I have to explain, and I have to tell about safety netting. Okay, pulmonary embolism, doctor. This is very critical in a way because we will be getting many things from the patient, but where we have to talk about opening statement. Okay, then rapid assessment, we have to see patient current status like say SOB at rest or chest pain or hemodynamic stability. Focus assessment, doctor, we have to talk about chest pain, hemoptysis, or syncope. Risk factor, doctor, as always, patient, we have to ask about recent surgery, immobility, pregnancy, OCPPLs or HRT, patient having cancer on chemotherapy or any therapy, or previous DVT or pulmonary embolism or leg swelling. In the examination, doctor, always mandatory to know about patient's general physical examination, always. Okay. Then you have to go with a systemic examination. Like say, patient always look for the cough. Okay, there will be agenda that their patient having a long travel history and patient having tender cough. Patient didn't given the history about lower limb. Patient they will be hiding the story. Okay, but you have to look at the patient lower limb. So examination finding they will be showing that okay, patient having tenderness or swelling at the left calf or right calf. What are the key actions you will be doing in the examination? You have to check about patient A, B, C, D, E, oxygen if patient is hypoxic, and we have to recognize pulmonary embolism from the story and the risk factors. Okay. Then apart from that, doctor, we have to send this patient urgently. We are not going to send this patient home. Okay. Because if you are sending this patient home, it will be considered as an improper and incomplete, and we call it not a safe doctor. Okay. We are going to send this patient urgently for imaging and anticoagulation therapy. Communication doctor, we have to explain about the clot in the lungs and need for emergency hospital test and treatment. Patient will be resisting over here. So you can say, Mr. Khan, your health is more important to us. Okay, I can understand your job more matters for you, but at the moment you are not able to do you are not able to go to your job. So you have to convince the patient. So stroke and TIA doctor. Now, this patient, like a stroke patient, might come with in a dual agenda with uncontrolled hypertension. TIA patient will be coming with a story, doctor. I have AF, previous AF history. Okay, so they will be coming like this, and they will be asking about some funny things. Okay, funny things. What, doctor? You have to think about now. Opening statement. You have to come to confirm the last seen well. Okay, and onset and progression of the symptoms. Do fast in front of the examiner. That is a mandatory for you. Focus assessment, doctor. We have to look about patient weakness, speech, vision problem, balance, and headache. Okay. Then, if patient is taking any medication, we have to we have to ask about anticoagulants and vascular risk factors. Always check patient glucose level because if like say patient with a stroke, so they will be having some deterioration. Either patient will be in hypo or hypoxia, hyper. Brief neurological examination. Either we have to do check one limb power or sorry, both limb upper and lower. One side you can do it and visual fields. But for example, patient having weakness on right side, I should not touch that and should not say that I'm going to check your this one. Patient is disabled. I'm going to force him to do his affected limb. So it will be considered incomplete and failure in the exam, no matter whatever your data gathering, no matter whatever your diagnosis. But if you say the patient, I'm going to check your this right limb, which is affected already. So they will be saying, this doctor is not a safe doctor. He's giving pain to the patient. Key action doctor, we are going to treat the patient as a stroke and ongoing stroke, calling the emergency transfer to the stroke center or nearby emergency department. Okay, we are going to explain that you need a CT head injury, CT head urgently, and possible thrombolysis or thrombectomy, whatever, as per the scenario. But for example, for the TIA, doctor, which is resolved, huh? So what you will do?
Excuse me, Dr. Imran.
Yes, doctor.
Yeah, doctor, you said that in this stroke, we should not touch the affected limb. Then how
Yeah.
we will come to know on the examination that there is a weakness and paralysis?
Doctor, patient will be, you will be on while performing the examination, Mr. Khan, are you able to move your are you able to move or you sense your right upper limb? He said, doctor, no. Okay, when he said no,
Mm-hmm.
means no. There is no such thing that I'm going to examine you on the right side. Patient say no means finish.
Okay, in that case, we will do the hand gripping only on the right unaffected hand, you mean? But it will
Unaffected
be
hand, yes.
normal by anyway.
Normal anyway, but you know that patient say no means like say same patient complaining of the pain of abdomen and you are not going to touch. Do you think that you're going to touch the patient in the pain? Patient will not allow.
No.
Yes, here you go.
Mm-hmm.
Okay,
Okay.
so yes, doctor. For the TIA, doctor, fully resolved. We are going to send this patient urgent specialist assessment same day or next day, and we have to give antiplatelet if appropriate as per patient condition. Okay, so when patient, Dr. Afsa, when patient don't have any movement, no movement on the side, so we won't force the patient to do this thing. Because this came in my exam,
Okay.
Dr. Subarachnoid hemorrhage. Patient was holding his left arm, and it was he when came in front of him, he deliberately he throw his arm down, and it was like say powerless. Then he pull his hand with his help. Then I help him to pull his hand on to keep on lap. Okay, examiner, they wanted to notice whether you're taking care of the patient or no.
So, sir, this TIA patient, we have to give aspirin, right?
Aspirin, how much, Dr. Kamlesh?
300.
Yes. Okay, we have to clearly explain the patient pathway, what patient we are going to do with the patient. We have to explain the suspected TIA or stroke and time critical nature. We have to explain. Patient will be saying, Doctor, give me the medication for my headache. I want to go home or I want to go to the work. Later I will go. No, you have to say, Mr. Khan, I can understand your condition. Your condition is not that good that you can go home right now or you are at work right now. The reason because you need a urgent treatment or urgent intervention. Okay,
Doctor, I
doctor.
have a question
Yes,
about
Dr. Amisha.
crescendo TIA. Do we give aspirin or not?
I'm not getting it, doctor.
Crescendo TIA, the recurrent TIAs. What the latest guidelines say to give aspirin in crescendo TIA or
Any
not?
document, can I add in it?
Yes, please.
Hmm.
Anything that is in crescendo manner, like crescendo angina, or if TIA is more than 24 hours, this is different for TIA, not crescendo. Okay, there is no crescendo for TIA. Okay,
Okay,
but in crescendo angina, you have to refer the patient. What is crescendo? That the patient got the pain worse than the last pain, and it was worse than the last pain. Okay, so in this manner,
okay,
every time he is getting the pain, it's worse than the last. In that manner, we have to refer the patient.
okay. We
That's
will
crescendo.
not give any medicine
Yes,
on
doctor.
our own.
Yeah,
Okay, okay,
yeah, but these cases usually don't appear a lot in exam. This is
okay.
mostly stable angina that got worsened and became NSTEMI. Then you have to refer, or otherwise it's newly diagnosed in your clinic as angina. Then you start the medication and get the follow-up.
Yes, doctor. So, doctor, for seizure and first fit, either patient come as a proxy for the child, okay, like say we call it febrile seizures, okay, or what we will be talking about, a patient will be sitting in front of you and they will be simulated, okay. So, we have to know about and how we if like say patient is simulated for example over there, we have to protect that patient from the injury, remove the hazard and loosen the tightened clothing and time the seizure, place something soft under the head and do not put anything in the mouth. Okay, this is out of the world scenario but that scenario is quite possible. Post ictal, okay, we have to ask go with airway and breathing recovery position. But for example, patient is a child, mother is coming to you talking about febrile seizures. She's thinking that her child is having seizure or epilepsy. So then we are going to ask about the duration, when it happened, how many time it happened, who noticed, and how you did, and how is your child. Okay, if patient vomited or not, patient loss of conscious, okay, or how is patient state. So it means like say there are red flags. If you get any red flag from that case, because mostly patient comes with a seizure first fit from the child. This is a proxy case in the MRCGP exam. So here we have to know if there is a red flag. We have to say, Mrs. Khan, I want you to see a child right now, or you have to bring the child right now in the emergency department. We need to rule out further. Okay, if patient got within 24 hours, second time, this is also red flag. Okay, and first time seizure also is a red flag, doctor. Okay, so we need to, this is a red flag, so we need, here examiner wanted to know about how attentive you are to talk, get the patient, safety. Okay. What are the key actions are there, doctor? First seizure, always urgent emergency department referral for the workup. Any prolonged seizures, more than 5 minutes or repeated emergency services. Okay. Or some cases they will be thinking about benzodiazepine. Maybe some regular patient who is on medications, he or she is having concerns about benzodiazepines. They might arise, that situation might arise. Okay. Communication, again, we are going to reassure the patient or proxy, okay, advise not to drive if the patient is driving, or importance of hospital assessment. But in elderly patient, epilepsy case will come as the patient want to get pregnant or patient is a pregnant. If male is there, we have to say that you should not try to conceive, to try not to get a baby in the 3 months after stopping the treat medicine. For the female, it's a 6 month. Doctor, this will be the agenda in the case.
Can you repeat, Dr. Imran, this?
Okay, doctor. For example, one scenario arises, doctor, one patient comes to you and she say that, doctor, I am pregnant. Okay, when you ask about history, she is known case of epilepsy. She is on medication, anti-epileptic. Okay, this is a contraindication in the pregnancy. Okay, so we have to stop the medication or we are going to refer the patient to the neurology on a neuro department. First of all, second thing, if sometime patient come for the counseling case, doctor, I wanted to get pregnant, but I read on Google that anti-epileptic drugs are contraindicated for that one. Can you tell me what to do next, doctor? Because I never got. So we have to know that since how long, you have what you call it? Since how long you are having you are fits free. So based on the duration, then we can talk about and we can stop the medication, or we cannot stop the medication. We can refer for the neurology for further counseling or management. Okay, but if already patient is a seizure free more than 1 year, so now we can talk about, okay, after stopping the medication at least for 6 months for the female, okay, and 3 months for the male, okay, so they can try for the baby.
No matter which type of medication they are taking, or there is a specific medication for that, for the male, for example.
Doctor, I think sodium valproate, if I'm not mistaken, doctor.
Yeah, sodium valproate, it is for 6 months, I think, for a
Yes.
female.
Yes,
For
and
male
3 months
also
for
6 months?
3 months, 3 months.
Okay, 3 months for male.
Yeah.
Okay, doctor, but what
I
about if a patient is on medication and then duration for like 1 year, 2 year, like
Not getting you, doctor.
means no any attack during the last 2 years, like, or in medication there is a separate way
No,
if
a
patient
patient
is
is
on medication.
patient is on a medication, but he don't have any problem. Okay, he's taking the medication. Yes,
Mhm.
they don't got any seizures last. So we are going to refer the patient. Doctor Hafsa, sodium valproate and carbamazepine. We have to 6 month and 3 month. Okay, lamotrigine and Levitra centrum is safe actually. Okay, last 3 years. Okay, attack free, can drive.
Yes, sir. That is that if the patient is free of seizure for the last 2 years with medication, then she or he can conceive if provided 2 years free seizures, isn't?
Yes, doctor.
And so, Dr. Iman, also you said about the benzodiazepine. How can that be in epilepsy? Like
Doctor,
what in what scenarios it can come?
Doctor, that scenario will come, doctor. I'm taking this medication. Okay, some side effect might arise, some sort of concerns and queries are there, doctor. So you have to address those queries and you have to ask about compliance and how often he's taking, whether he's adherent to the medication dosage or not. So these are the agendas are there. Okay, and simple thing we have to talk about. For hypoglycemia, doctor, everyone knows, so I am not going to say much. This is always emergency cases, but cases we have talked a lot. So suspected DKA also. This is a doctor I am talking about as MRCGP syllabus cases. Okay, so they are wanted. These are the topics from there. Okay, what they are testing you on in the exam. Okay, give me a moment. So. Acute heart failure and pulmonary edema, doctor, mostly patient will come is now like say, let me tell you, this agenda will not be coming with a young patient on middle age. This agenda you will be seeing the patient more than 65 years old. Okay, so you have to keep in mind. One. Number two, patient will be having severe breathing difficulty. Doctor, I am having problem in sitting upright and feeling distress, speaking short sentences, and most of the time, doctor, they will be telling doctor, my limb swelling is there. Okay, I have some problem while going to the washroom. I can't go to the washroom. Doctor, I can't do the thing. And sometime, doctor, they will be coming after as a follow-up patient from the hospital. Doctor, I don't know what medication they given so far. So they will be talking about furosemide. Okay, they will be talking about other medication. So you have to talk about and you have to explain each and every medication and then safety netting and then you have to check your weight regularly basis, salt reduction and water, how much water patient have to take. So every day patient have to check the weight. These are the agendas over there. Okay, so focus assessment, we have to see that whether you got this sudden or gradual. Okay, so it is based on patient condition, whether you're getting orthopnea or not, PND, chest pain, palpitation. Doctor, either one you can talk and you can discuss about from the patient. Okay, examination, doctor, is mandatory again. So you will be getting chest crackles, raised JVP, peripheral edema, and new murmur. Anything if you're getting, this is an emergency referral. Okay, this patient need hospital admission rather than sending with a water pills. Immediate action, doctor, make patient sit up upright. Patient, if you said you lie down, so lie down doesn't work over there. Many cases you have to put the pillow under the neck. Many cases you have to take out the pillow from the neck. Okay. Here examiner want to know from this thing also that how you are going to relieve the patient. Okay. In this patient, you have to keep the pillows, one or two or three, whatever, so on. But in abdominal cases, doctor, you have to remove the pillow. Then you are going to monitor IV access. Then you have to say, I will be doing ABC. Like say, I will be doing ABC, or you said I will be adjusting two IV bore needles, and cannula access, and I will be taking your ECG right now, and I will be doing anti-pro-BNP. Okay, and emergency transfer to the hospital. Why, doctor? Why are you sending me to the hospital, doctor? So you can say, Doctor, Mr. Khan, as now I can see that your lungs having some sort of water, and you see that your lips swelling is up to the knee. So it need a hospital admission for injection, which will remove the water from your body and further management. Just simple way you have to explain. Okay, communication always you have to explain acute fluid on the lung, your heart is struggling or need urgent hospital care. Doctor, anaphylaxis cases will be coming. Doctor, I went to the hospital, I went to the jungle, I went somewhere. We had to ask about sudden onset after the allergen exposure. I exposed to the grass. I ate some food and after that I got the problem. So you have to assess patient airway about any swelling or stridor, any voice change. Did you got any funny sound in your chest or breathing difficulty? How about you feel dizzy or you feel that heart is racing or you feel that you are going to collapse in simple language? And is there anything, Mr. Khan, you see that your skin got some rashes? You got said that your his skin is hot, not flushing, doctor. Have you got that any swelling of your lips or other parts of the body? Then what will the emergency reaction? So they will be, if you say this thing, so examiner will give you, sorry, SP will show you the picture. Okay, SP will show you the picture. So here in the picture, you might say that some sort of urticaria or angioedema. Means is anaphylactic shock. Dr. Iqbal, please keep your mic mute, please. So here, if you say this thing, sorry, SP will show you the picture. Picture will be there. Either Dr. Iqbal, please mute. So, if like say you got any angioedema or flushing or urticaria on the picture, or examiner giving you the reading of hypotension, tachycardia, or collapse, or on the chest examination you find out patient having wheezing. These are the immediate action you need to do it over there. You are going to call the emergency services, Mrs. Khan. I'm going to send you over there. Tell the patient to lie flat and legs raised. If patient having hypotension, I'm going to give you Mr. and Mrs. Khan, I'm giving you one injection. We call it intramuscular adrenaline. Okay, I'm giving you lateral thigh. You have to explain where you're going to give, doctor. Okay, correct dose. Repeat every 5 minutes if it is needed. I'll be telling Mrs. Khan. I'll be repeating every 5 minutes till you get better. Okay, high flow oxygen if patient is having hypoxia, considering IV fluid patient having hypotension, and what I will be monitoring till the ambulance arrive. So here examiner want to know how you are able to deal with emergency situation if arise in your clinic. Okay. Then meanwhile, Mrs. Khan, ambulance is rising. I'm going to explain you what happened to you and what will be that agenda. And once you discharge from the hospital, how you will be coming to me, and then I will be referring you to the allergy specialist because she got first time. Have you seen in past medicine and AKT that first anaphylaxis reaction here? If you are not explaining this thing, we call it pitfall. The reason, because examiner, this is the first time. So we have to know about the allergic thing. Okay. Patient needs some sort of pen. What do we call it? I forget the name of the pen, doctor.
Doctor
EpiPen. EpiPen.
EpiPen. For EpiPen, we need to refer the patient. Okay.
Doctor,
So,
regarding this adrenaline dose during the exam, how to say like?
doctor, let me check. I'll tell you. Because I'm going through a big, only headlines to cover up because I'm not going into detail
No,
because
yeah,
these
I
are the.
understand, sir. Actually, it depends on, means if a patient is 50 kg, I know it is according to, because not
Yes.
everybody is there to calculate. So we have to tell according to your body weight, I will give, or just to calculate or give a round figure, like means what to do in the exam.
So I know you have to tell the exact dose because exact dose matters there. So I'll be checking. I'll be sharing in the group,
Uh,
doctor.
Dr. Imran,
Yes, yes,
for
doctor.
if I'm not wrong, for every age there is different doses. Yes, there was a chart we read somewhere, and if you can memorize it right now. Otherwise, in children it's different, like up to 10 years different, and above then it's different. So we can check it on the internet.
Dr. Kamlesh, these are we are talking about pitfalls. Pitfalls. Why pitfall? Because many candidates, many time we do the mistakes where we shouldn't do the mistake. Okay,
Yes,
so
yes.
ectopic pregnancy, doctor, is very important topic. Any fertile, any patient, a women in a reproductive age, until unless it is proven, we will treat them as a ectopic pregnancy. For your information. Okay, though you think this patient is a appendicitis, mostly the patient will be saying, "Doctor, I am having the pain on the right side." All the agendas where we have seen patient always come the pain on the right side to distract you from appendicitis with ectopic pregnancy, along with salpingitis or other conditions. yeah, renal colic or whatever, so on. Okay, so we have to see, ask about any bleeding down below. Okay, and we have to ask about last menstrual cycle from any female. In the case, you have to ask LMP first, then pregnancy test and pain and bleeding pattern we have to know about. Have you checked your pregnancy test at home by chance? Okay, by chance, are you pregnant? Okay, then focus assessment, doctor, risk factors. Is there any previous ectopic, tubal pregnancy, or PID or IVF? Many times patient will be coming with the history, doctor. I went through the IVF because we are trying for the baby for many years, but we are not conceiving. We are thinking we went for IVF procedure 1 week ago or 2 weeks ago. These are the risk factors are there. Doctor, red flags always. Doctor, my pain going to the shoulder tip. I'm feeling dizzy and collapsing. This is emergency. You have to check patient observations. Okay, sign for the shock, and after that you have to set what you call nil by mouth and refer the patient. Don't send patient home back. Key actions, doctor. Patient is stable. Emergency ambulance to the hospital and resuscitation at the site. If patient is stable but ectopic suspected, urgent same day assessment, early pregnancy assessment, or to the gynae. Okay, do not reassure as a miscarriage and same home and we are sending home without assessment. Okay, this is a pitfall. We have to explain patient properly. Okay, that
Sir,
pregnancy outside the womb. Yes, doctor.
sir, for ectopic pregnancy, if vitally stable, can go with the family member as well in the car. But
Yes,
emergency,
same
vitally
day
unstable in the
Yeah.
ambulance.
Yes, doctor. You got my point, Dr. Kamlesh.
So, doctor,
Yes,
for
sir.
the for the stable, she can go by herself in her car. But if it is
Yes, doctor.
unstable, then she can go by the ambulance like this.
Obviously, any patient vitally unstable should be with the ambulance only. I think.
Doctor, this is very simple. That's the reason. These are the pitfalls are there because we are not able to recognize between emergency and non-emergency patient. Okay, though this is an emergency patient, but patient can go to same day to early pregnancy test assessment. Okay, if patient is stable, but if patient is unstable, we have to send this patient with emergency. Okay, so this is what examiner wanted to know whether you are able to recognize this thing or no. In doctor, newly diagnosed hypertension, patient will be coming with some agenda mixed with metabolic syndrome or accidental finding. Patient don't have any symptoms, or patient come with a history of headaches, persistent headache. Okay, he went to the pharmacy, he checked his blood pressure, it was high. Now that was only one reading. In our domain, we have to take proper history. Okay, cardiovascular risk factors assessment and secondary causes. Then we have to examine the patient in both arms. If you say that I'm going to check your blood pressure, I am not verbalizing that both arms, it will be considered incomplete and incompetent. Okay, and I'll be checking your BMI waist circumference, doctor. It is mandatory over there. If you are not doing in the examination, it will be considered incomplete. Okay, always look for proper cardiovascular examination, and you have to do some investigation. And for example, you have only one reading at clinic, then you are going to send this patient with home blood pressure monitoring, and you're calling the patient after 1 week with the reports. But sometime agenda arise that patient having 3 readings. Okay. Now this case, you are going to treat the patient, but before treating the patient, you are going to check some baselines and you are going to send for ACR or whatever so on, depending on the age. But if patient is younger than 37 or 40, okay, you are going to refer this patient to the cardiology, not going to treat this patient. Agenda lies over here. So young patient we cannot treat in a GP setting. We have to rule out any secondary cause.
Secondary cause, yes.
Okay, so here, though I know that I'm going to start, a patient is going to take the amlodipine or valsartan, whatever, so on, but still I have to see that patient age.
Dr. Imran, in this similar case, but can we request the blood investigations or not? Or should we send them directly to the cardiologist?
Doctor, I will be, if like say, for example, you say that you need to do some investigation, doctor, what? So you can say in your wording, I'll be checking your full blood count, urea electrolyte, EGFR, lipid panel, and sugar panel, along with urine if analysis for the protein and any blood and ECG. Okay, and once the report will come, we will be posting over there or we'll be sending over there. Okay, because this patient is not an urgent referral. Okay, you're going to send this a routine referral. Am I right?
Mm-hmm.
Okay. Yes, patient having blood pressure 160 by 105 or 110. This is emergency referral, doctor.
Mm-hmm.
So these are the things in a newly diagnosed hypertension. Management always, doctor. As I told you
Dr.
guys,
Imran, Dr. Imran, I was thinking that for the same patient, like, can we do metanephrine and all this, or we should not? This is done to be done by cardiologist.
done by the cardiologist.
Okay, okay.
Poorly controlled hypertension, very simple case, doctor. Very simple, pretty simple case, and you don't have to dig much, but typical. Why it is typical, doctor? Because there you have to ask about reason to visit. If, like, say, patient say, doctor, my blood pressure is not getting better, my medicines are not working anymore, we have to see about the compliance. Okay. Number two, doctor, we have to think about focus assessment. Okay. So we have to see that how do you know that about, have you checked that blood pressure? Have you seen that, what you call it? Have you checked the blood pressure at home or whatever, so on? Then patient will be telling you the story. Oh, doctor, I'm getting the headache. I'm getting the blurring vision. So we have to explore adherence, side effects, or lifestyle. Doctor, I can't take care of my food because I'm taking food from outside. Doctor, I like the salty food. Okay. I can't control weight because my knee joint pain. Okay. The agenda lies over here. I have to ask about mention about any modified exercise protocols. Okay. So we have to always check about end organ symptoms, like say, do you have any chest pain, shortness of breath, palpitation, or claudication? Based on the patient age, we have to talk about. If patient says, I have headache, we have to talk about neurological symptoms and claudications. Okay, if patient says that I have the chest pain, we have to talk about palpitation, SOP, and chest pain. If patient says, doctor, I am having blurring of vision, I have to talk about neurosymptom along with SOP and palpitation and claudication. So this is based on the scenario, doctor, because there are many hundreds, many scenarios are there where we can't go, but the thing we can talk in general. Examination must be proper. Okay, investigation, if not done for a long time, we have to repeat it. If it is done that within 3 months, we should not repeat. Patient will be showing that investigations. And we have to check whether patient is checking blood pressure regular in proper way or no. And then we have to repeat manually. You have to check patient BMI on other general physical examination. Recent labs and ECG if done. If it not done, we have to consider to repeat. Management, as always, address adherence and lifestyle first, non-pharmacological. Mr. Khan, if you're not taking the medication, it will be a dangerous for your life. As you see that you came for the headache, persistent headache. The headache reason is because your blood pressure is continuously higher on side. Okay. And we are going to review the regime. For example, if it is patients are taking amlodipine 5 mg, we can increase the dose. Okay, step by step. Okay, and up titration and adding second or third drug. If patient already taking 3 drugs, fourth drug should be by the specialist, not by you. Okay, and we are going to screen for secondary causes if patient having resistant hypertension. Patient already compliant with the medication, everything is going on. We need to rule out any secondary cause. Either it is a renal or whatever, so on. Yes, doctor, shared plan is very important. You are going to say, Mr. Khan, Shall we discuss the management plan with you? Mr. Khan, as you know that you are taking the medication and you're concerned that these medications are many, you are taking 3 or 4 medications. So, Doctor, Mr. Khan, what do you think about that? If you are taking instead of taking 3 or 4 drugs, you will be taking 2 drugs. How sound like this? Do you are you comfortable with that one, Doctor? It will be pretty fine. It doesn't mean, Mr. Khan, I'm going to reduce the medication, but there are many medications comes in combination. Okay, so we will be making your combination drug and we will be making your life easier. So many time patient is fussy. Patient is tired of taking many medications. So we have to think about combination dosage. Counseling the patient, Mr. Khan, at the moment they will say, Doctor, reduce my medicine. Mr. Khan, it is not possible to reduce the tablets, but number of tablets, yes, we can reduce it. Doctor, how it is possible? Then you have to talk about combination drug. Okay, then you have to explain about the risk. Mr. Khan, if you are not taking care of your blood pressure properly, there are chances to get stroke, MI, kidney disease, whatever so on. So we have to make him scare actually and safety netting, doctor. This is one of the most favorite case in exam. Stable angina. Patient will be coming with a history, 1 or 2 episodes, but now again agenda arise where patient got this chest pain. It was whether it was exertional or not, it was relieved by the rest, or patient already taking some medication with the GTN, or the duration. Focus assessment, doctor. Chest pain features. Always talk about Socrates. Okay, side, character, radiation, and relation to the exertion or emotion. Maybe I got angry. Maybe I was walking uphill. Maybe I was running towards for the bus. Maybe I was in hurry in a shopping mall. Okay, and if patient is getting any pain at night time, it is worry. Okay, because of we call it unstable angina. Okay, then talk about risk factors, doctor. Okay, if patient having smoking history, high blood pressure, high lipid, and diabetes, family history, and previous MI. Okay, so doctor, red flags, doctor, we should not, miss increasing frequency or severity, pain at rest, and associated shortness of breath and syncope. If patient already taking the GTN, so we have to talk about any drug, like say, Mr. Khan, are you taking any medication for intimacy? Okay, like what, doctor? Like say you're taking sildenafil or tadalafil. If you are missing sildenafil and tadalafil and you are mentioning about GTN, giving the GTN without asking, it will be considered incomplete or incompetent. Many candidates, they are losing the station, they are losing the marks on this thing. Okay, examination investigation always needed, blood pressure monitoring, everything needed. But the thing, whatever is important, that important, some pitfalls are there, what we do miss. Management, doctor, everyone knows short acting GTN, how to use, maximum dosage, when to call the ambulance. This is the important part. We can think about beta blocker and calcium channel blocker, but some school of thought say that we have to leave this for the specialist if patient is getting for the first time. Prognostic treatment, always we are thinking about antiplatelet if integrated. Then we are going to start AC inhibitor, statins if appropriate, lifestyle modification, and explaining the condition and aims for the treatment. Clear advice, doctor, when to treat an emergency. Okay, now agenda might arise. Doctor, I took sildenafil last night. Patient is in the pain now. What you will do? Anyone having idea?
We will refer
Yes,
We'll
emergency
give,
we will.
admission because we can't give
as
nitrates.
Yes, doctor. That's what examiner want to know about know from you. Atrial fibrillation, doctor. Funny movement in my chest. We have to think about what patient is saying. Patient understanding. If patient having old or previous or episodic palpitations. Okay, then assessment. So assessment, doctor, symptoms, palpitation, SOP, shortness of breath, whatever so on. Triggers. How do you get Mr. Khan about this? Doctor, when I'm taking alcohol. Doctor, I think it is related to the coffee. Doctor, no. I got last week one in I treated from an infection last week. It means recent infection. Doctor, I have this painful, nodule in my neck. Think about thyroid disease. Doctor, I have a lot of tension at work. Think about stress. These are the trigger factors are there. We have to rule it out. Then duration. Whether we have to think about proximal, persistent, or permanent. Okay, stroke risk factors, doctor. Then we have to think about age, hypertension, diabetes, heart failure, vascular disease, or previous stroke or TIA. Okay, if patient having history of GI bleed, liver disease, alcohol excess, and falls, these are the bleeding risks we have to find out. Patient is elderly. Mostly, this kind of patient will come an elderly patient with palpitation, doctor. Um, Case will come as a panic attack. That in palpitation, there are three agendas might arise: hyperthyroidism, panic attack, and uh, stress, whatever so on. So we have to carefully dig it out. Examination, doctor, for the AF always will be getting irregular. Examiner will give you a finding, and patient will be telling you about ECG findings, and then you're going to rule it out, and you're going to order few investigations. Management, doctor, as always, um, rate control versus rhythm control based on the scenario. Brief explanation, not full details in OSCE. Don't go in details. No examiner don't want you to listen, and there is no agenda. There is no yes, this is I'm talking about as per MRCGP syllabus, not talking out on based of any other courses, doctor. And anticoagulation, doctor, we have to explain about risk. So that I will be doing some risk score like say Cadwick scoring. Then you have to think about docs or warfarin, whatever as per the local guidelines, doctor. Lifestyle, doctor, you can talk about counseling and safety netting, and you can educate the patient about pulse checking, adherence to the anticoagulant, what to do with the bleeding or new neurological symptoms. You have to teach the patient. This is the agenda. Okay, chronic heart failure management, doctor, pretty simple again. Patient, we have to confirm the diagnosis. Patient either will be coming with echo evidence if patient is known, or coming from the hospital. Recent, patient don't know about the medication, patient develop some new symptoms, or it is impacting on his daily life. Okay, so we have to talk about SOB, orthopnea, PND, ankle swelling, whatever so on. We can go ahead and functional status, NYHI class, style questions you can talk about. Okay, drug history, fluid and salt intake. Mr. Khan, what do you think? How about your diet? Doctor, I like salty food more. Mr. Khan, how much water you take? So, doctor, I feel more thirsty. It means the agenda lies over here in psychosocial. So we have to think about that. Patient is taking a lot of alcohol. Patient is smoking. Examination always mandatory, but always don't forget uh, to check patient peripheral edema. Weight. I'll be checking your weight according to I. Though patient mentioned that I have BMI 25, but I'll be checking your weight again. Okay, examiner will give you finding BMI not 26. Okay, you have to auscultate the lungs, peripheral edema. These are the mandatory things are there. In your GP setting in OSCE, you have to think about recent bloods. If not done, then you're going to repeat it. Management, doctor, I have spoken already. Yes, my favorite topic. Um, this kind of case can come in different stories. Doctor, my friend, today one exam case came like this one. My friend died because of heart attack. His cholesterol report was same like me. Okay, patient having some fear to talk about, and patient want to know about lipid management or lifestyle management, or patient need both, or patient need referral because patient is lying in the category of metabolic syndrome. Okay, or patient is hypertensive. but he's not taking any cholesterol report, but he's coming with a report. So you have to ask, what do you have any other report? So he will be showing another report to you. So you have to match with that one. Agenda lies over here to see the percentage of improvement or worsening condition. Okay. Then explore the concerns, explain about the role of cholesterol and how statin works and what will be the side effects. And sometime, like my exam case came, statin-induced myopathy. Doctor, I am having severe pain. Okay, since how long? 6 weeks. Okay. And I asked about drug history, then patient didn't give me anything. I treated as a fibromyalgia. My colleague went, they given her that I am taking this medication, statin. They treated as a statin-induced myopathy. Both are right. Why? Because on examination finding, they given me tender point. Okay. On examination finding, they given normal finding on mild tenderness. Both cases are fine. Because if I forget to ask about or she didn't giving me deliberately that I'm not taking any medication, so it means I didn't say that I should not say that I did my case wrong. No, my case was right. The reason, because either I missed the thing, either she missed the thing, either she deliberately hide the thing that she's on a statin tablet. So we have to rule out: are you taking any? Are you on medication recently, or did you start any medication recently? About what, doctor? Any blood thinning agent or whatever, so on, lipid, fat medicines or whatever, so on. Then patient will give you the history of lipid management. Here we have to talk about non-pharmacological before, then pharmacological. It is a shared decision making, doctor. You have to use risk figures where possible, like say Q risk. Okay. Address the misconception. Mrs. Khan, I can understand that you have a misconception. It might not be you that people think that you will not be getting the pregnant. No, Mrs. Khan, it is not like that. Yes, it is a contraindicated in the pregnancy. So whenever you are going to try to pregnant, whenever you're planning for pregnancy, come to us, we will stop the medication. Okay. Then we have to talk about diet, exercise, and other lipid lowering agent if patient is not tolerating that statin. Counseling and safety netting, and when to take the medication, how to take the medication, and how long it will be. Doctor, really, I'm taking only for 3 months. No, Mrs. Khan, it is not like this because you are suffering from the condition we call it familial hypercholesterolemia. It means that genetically you are prone to get cholesterol. For that one, you need to take the medication for your betterment or for your better life for lifelong. So to explain when to seek the advice if you are getting severe muscle pain, if you're getting dark urine or yellow skin or eyes. Doctor, this is very small cardiovascular risk assessment consultation. This is this one is not coming in the exam, so it is very small, so leave it. Asthma diagnosis and inhaler counseling, doctor. One of the most commonest tested, and one many candidate they don't pass this station. Very simple station, but they fail. The reason? We are talking about history, but we don't talk about how patient is using the inhaler, and we are not teaching the patient inhaler technique. This is the main agenda of this thing. And yes, trigger factors. Maybe patient recently shifted to new house, as I talk about in acute exacerbation of asthma, or patient had some sort of some food pattern changes, or maybe patient having past history, maybe patient having some sort of daytime he's getting. Yes, agenda lies over here, doctor. I am getting better when I'm at home. It means patient having occupational. I have to send this patient to occupational medicine, not to treat from my side. Okay, examiner want to know that where you're sending the patient, whether you're treating the patient with occupational asthma, it means you are incompetent. You didn't recognize that patient having occupational, um, occupation related problem. So we have to talk about this. Simple explanation, doctor, and stepwise treatment, reliever versus preventer, inhalers, when to use and when to step down or when to step up. Okay, inhaler counseling is important part over here. Okay, we should not miss. We have to choose the device appropriate to the patient. For the babies, we are using spacers. For the babies, you cannot give the inhaler. For example, in 2025 exam, May Karachi, April or May Karachi, agenda was there. Mother came, doctor, my child is having breathing difficulty. Okay, Mrs. Khan, may I know what, can you tell me more about it? Doctor, my child started going school recently. It's been now 10th day of school. And yesterday, nurse called me that your child having breathing difficulty, and they given some sort of treatment, and patient is fine. I'm worried about my child. Okay, Mrs. Khan. Mrs. Khan, is there anything else you want to add? No, doctor, he's all right. He was playful boy, and he never got such thing. But Mrs. Khan, can you tell me exactly when it happened? Mrs. Khan says, doctor, my child was playing. Suddenly, he ran short of breath. Means exercise induced asthma. Okay, Mrs. Khan, I can understand. Mrs. Khan, can you tell me, is he suffering from any medical illness? Like what, doctor? Any skin problem? If she say eczema, so you can relate with atopy. If she's saying, doctor, um, no. So, Mrs. Khan, in your family, anyone suffering from the condition, lung condition or breathing problem? Yes, doctor, his father is asthmatic, or I am the asthmatic, or brother is asthmatic, or grandfather is anyone is asthmatic in the family. So means now agenda lies over here. Mrs. Khan, from your history that you told about Mr. Majid, I am suspecting that he's suffering from the condition what we call it exercise-induced asthma. And you're right, as you are suffering, or as your husband is suffering, I'm expecting that to rule out further. I need to see your child. Okay, is that okay for you? Can you bring for your child? Can you bring your child? Okay, doctor. So once your child will come here, then we will be examining him properly, and then we will be treating him. Now treatment lies over here where I'll be sending you to the pulmonologist. But patient is a middle age, exercise-induced asthma. First time he got it, I have to send the patient with simple technique, simple medication, or simple measurements. But in this was the case of asthma case in May 2024, so 2025 Karachi. So this case might arise over here, chances. And yes, and proper inhaler technique, okay, when to use the reliever, when to use a preventer, that everything you have to explain, side effect. And after usage, you cleansing the mouth. If you didn't mention the cleansing the mouth, it will be considered incomplete and incompetent. Okay, asthma action plan you have to give. Red flag you have to talk, explain. So this is about asthma. COPD, doctor, plus minus same. But what is the difference between COPD and in asthma? The COPD patient will be elderly patient with strong family, a strong smoking history. Asthma patient will be young patient or child. This is the difference. Rest story is same. Okay. Occupational exposure we have to rule out. Smoking history we have to rule out. Previous exacerbation we have to rule out. This kind of patient will be coming with follow up. They are not a newly diagnosed patient. In exam, they don't put any newly diagnosed patients. Smoking advice, it comes with a smoking cessation agenda. Chronic cough and hemoptysis, doctor, one of the most favorite again. So there are many possible differentials are there from asthma, COPD, bronchiectasis, TB history, ACE inhibitor usage, GERD, post-nasal drip, so on, doctor. This is is a Friday market where you talk about many things, but you can concise in a way, Mr. Khan. Are you suffering from any illness? No, doctor. It means you rule out COPD and asthma as per the age. Bronchiectasis, you rule out about patient occupational history. or smoking history. Mr. Khan, have you traveled anywhere or anyone is coughing in your house? You ruled out triple history. Mr. Khan, are you taking any regular medication, AC inhibitor usage? Mr. Khan, are you suffering from any condition like heartburn? You rule out GERD. Mr. Khan, do you have any thing you're dripping from your nose back to your throat? You ruled out postnasal drip. Okay. So this is very simple. Mr. Khan will be telling you everything. But if you ask in a way, then you will be able to dig out the history. Because chronic cough and post viral cough, these are the most common scenario where they're having what you call it, hidden agendas are more. They are mostly we overcome or overrule the things. Examination doctor will be there, but if patient having post-viral cough, don't go for any investigations. Okay. But if patient having chronic cough, we have to identify the emergency. If patient having large volume of hemoptysis or hemodynamically is instability, we have to send this patient emergency. But non-urgent, but serious suspicion. For example, patient is elderly, you're suspecting is a cancerous pathway like say sublung CA, don't break the bad news over there on the chest X-ray. You say, Mr. Khan, I'm suspect. I have from the history and examination and on your chest finding, we need to rule out further what exactly the diagnosis. For that, I'm going to refer you to the hospital. Don't say that I'm suspecting that you have some sort of cancerous something or something dangerous over there. Don't use the word dangerous. Mr. Khan, I'm suspecting, and to confirm further and to get clear diagnosis to further treatment, I need to refer to the specialist for further treatment. Doctor, what? They will be doing MRI or bronchoscopy, whatever, so on. Okay, Mr. Khan, I wanted to do the further sputum culture or TB testing or spirometry, CT chest as per the specialist advice if like say patient come as a follow-up. We are going to explain patient concerns and proportionality.
So, doctor, if the patient says, Doctor, what you are suspecting?
Mr. Khan, at the moment, I'm not in the position to tell you and in this history because this is not a screen. This is a screen. This is a simple test. Okay. To come on to the conclusion, we need some specific test. Okay, doctor, can you take over? My throat is now not with me.
Yes, Dr. Imran.
Thank you. Okay, doctor.
Okay, so for tuberculosis suspicion or case or contact, there are a few things in the history points like patient might be coming with cough or fever or night sweats. So any fever differential or any cough differential should be a TB. And it might be some young person who will be coming and they might have a suspicion of TB. Like in recent cases, they told like I feel like I have a TB and I don't want my employer to know about it. So in that case, there are few things that we need to know about confidentiality, when to keep it and when to break it. So when we talk about the details in the case, what we have to ask, like if they got into contact with some TB, which TB was that? Could be extra pulmonary or it was the TB of the lungs. Okay, and 15 minutes of at least contact, close contact should be there. And yeah, for every TB case, there are a few things like HIV. If the patient is compromised like diabetes, then we have to be more extra vigilant for that case. Okay, for extrapulmonary TB, mostly there, if the patient got into contact with the secretions of the lymph nodes or in the neck, then they can get screened for the TB. Otherwise, there's no need to screen for just a contact that's not directly in the skin touch. Okay. In examination, always weight, pallor, lymphadenopathy, and in respiratory focal signs should be there. And they will be giving you focal sign for the pulmonary. Like on the right side, lower base, there is some dullness or dullness or percussion or consolidation. Next, doctor. And something in the TB should be like, remember, when you are starting for the new TB cases, just give them the details of the medication. Sometimes there is reports they are coming with. You can start with the medication right away. Like I'm going to put you on these medication. And second thing important is dot therapy. Third is you need to tell them the side effects. And the fourth is after 2 weeks, they have to be screened again. They have to be the retesting for gene expert after 2 weeks. And for those 2 weeks, they have to be wearing the mask and keeping all the precautionary measure because for next 2 weeks after starting the treatment plan, they are infected for the other people. Okay, so the next slide was pneumonia. Was it pneumonia? Yeah, pneumonia and the management and GP is always coming with cough, chest pain might be on the right side mostly, and maybe a COPD coming with pneumonia or a CAP, normally community acquired pneumonia. They might be telling you the sputum color or it's very short history. Don't mix it with the TB history because TB will be more than 1 month or months. But pneumonia is like 3 days back, I'm getting high grade fever, cough, and chest pain when I'm coughing, and localized right sided chest pain. And mostly this is age related, and sometimes there are young patients also. On examination, temperature, respiratory, SpO2 is important. How we assess, we have to, if you don't do the severity over there, like I'm going to check your CRB 65 score, you can either say it or either calculate it. Either of them is fine. Okay, if there is confusion, respiratory rate is high, blood pressure 90/60, or the age is 65, so according to that, you have to manage the patient. Mostly, the pneumonia, there is the empirical formula. If it's patient is not resistant to amoxil, then you're starting the amoxicillin for 5 to 7 days, or either if clarithromycin for atypical. And here, okay, so safety netting should be always like within 48 to 72 hours. There are few managements where you have to bring the patient within 2 days. Number one is pneumonia. Another is prostatitis. Okay. And these two cases are where you bring the patient in 2 days. Review the patient in 2 days. And also the third one is PID. So
Also, I
next,
think
okay.
Dr. Musarrat, diarrhea.
Sorry?
Dr. Musarat, it is
Diarrhea
pyelonephritis.
cases we will call after 48
Yeah,
hours.
pyelonephritis.
Pyelonephritis after 2 days.
Yeah, pyelonephritis. Diarrhea for 2 days. I'm not sure about diarrhea. If it's with fever, then it's different. Okay. So next.
So, doctor, we will be doing today 25 cases and 25 will be done tomorrow because it's already too late in Pakistan and many guys have to travel. So, we'll be doing tomorrow. So, I think another 2 or 3 slides are there. So, we'll be talking about, and after that, we'll be stopping to 25.
Okay. So sometimes there are cases like obstructive sleep apnea and OSA. Mostly, it's not coming like exactly OSA. Might be possible metabolic with 30 plus BMI. So every BMI you are checking it outside the examination hall. There must be written 30, 32. So make your mind for the screening of OSA. Okay, so you can ask how, like, do you snore at night, or maybe there is concern of their wife is telling you that I snore at night or I wake up choking in the middle of night. And OSA is very important because of the driving. So if there is OSA, patient might be coming for follow-up. He is 32 BMI. might be just wanting to get the medication, but you have to screen for OSA, then refer for the sleep studies, and if he's driving or um, uh, what we call it, HL2 driver or something like that, DV11 and 2. So if it's a car driver, then still he has to stop, and if he is a truck driver, then definitely he has to stop until the symptoms is resolved. And red flags is falling asleep while driving. So this is one of the important question in the history. Examination is again as you do in the metabolic, BMI, and the waist circumference. And one important is neck circumference in this case. And sometimes high blood pressure with the hyperlipidemia and OSA comes all along together. So you have to send the patient for the sleep studies. Lifestyle, as everybody knows, try to avoid weight loss, and if it's like 5 to 10% decrease in the weight loss, it will markedly like 50% decrease in total morbidity of the patient.
Dr. Musarat,
Okay.
in
Yes.
which cases we can check for waist circumference? Which scenarios can you
Metabolic,
just? Hmm.
yeah, waist circumference mostly when there is high BMI, number one.
Like for
And
example, if
when
the BMI is more than 30, then we should do.
yes,
Yes,
we should.
yes, doctor, and Down syndrome,
Central
doctor.
obesity. Yeah, Downs.
Down syndrome, and there is one more syndrome is there, Cushing.
For Down syndrome, also we have to do BMI.
No, no, no,
This
no, 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 not so Down syndrome. It's Cushing syndrome, doctor. When patient is saying,
Cushing
doctor,
syndrome.
I'm
Yes, yeah, yeah,
yeah, Cushing syndrome, yeah.
yeah.
Because
So
doctor, this
Cushing
down and
syndrome,
yeah,
metabolic syndrome, and any case in which the BMI is more than 30, we should do
more than
waist
30,
Yeah,
circumference.
and yes, yes, doctor.
yeah.
And also the
Dr.
hypothyroidism.
Hafsa,
Uh,
yes, yes. Outside the station, there is always written BMI. So mostly when you go inside and you're talking to the patient, you already know the BMI. So you have to make
okay.
this mind before entering. Okay,
Mm-hmm.
30 plus,
Okay.
and
Okay.
mostly PCOS. You are getting PCOS also central obesity because insulin resistance. There could be the hidden metabolic cause in PCOS. So you have to
Mm-hmm.
take everything all together, hypothyroid and all these.
Dr. Musarat, also in
Okay, so
diabetes,
yeah,
because
diabetes if their patient is having hyperlipidemic, deranged, glucose, hypertensive, and LDN, and then central obesity. So basically, this is all along metabolic in front of you, not just the diabetes. Okay, and uh, apart from this, there is waist circumference. There is calf muscle circumference. If someone detail me in which we check that calf circumference.
And deep vein thrombosis. Deep vein
Yeah.
thrombosis.
Yes. If you don't check calf circumference, then they won't tell you. Okay. So next case was dyspepsia. Okay. Gastrointestinal reflux disease. So basically, focus history mostly patient might be coming with nocturnal cough, sometimes heartburn, sometimes um, like indigestion of the food, but all together they are going towards the GERD. So between the GERD and gastritis, there is one thing that patient is telling you above the tummy, above the the epigastric. If he is getting symptoms, then it is GERD. But if he tells you that I have also pain on the left side of the epigastric, then it is gastritis. And in gastritis, you will be palpating deep in the epigastric region, and patient will be getting the pain. But in GERD, you won't get any tummy pain. These are the two things. And mostly GERD patients are here locally. What can be the case in these scenarios? NSAIDs use or any regular painkillers or diet and exercise. And again, it will come with what do you say? GERD and OSA sometimes it come together because of high BMI. And Red flags again, dysphagia, painful swallowing, weight loss, any blood in vomit, or any melena hematemesis. We need to ask all of that. Sometimes there is a patient with H. pylori report. So there you are not going to start only PPI. You're going to start all the triple or quadruple therapy for H. pylori. And you need to know sometimes patient is coming with the after the eradication therapy. Like, doctor, I took 2 weeks ago of all these medications and I want to retest myself, like urea breath test and test for H. pylori, stool test for H. pylori. So in that case, you need to know 2 weeks for PPI and 4 weeks of antibiotics, if I'm not wrong. So you have to tell the patient if it can happen now or you have to be 2 weeks late. Okay, so retesting schedule needs to know. Otherwise, smoking, alcohol management, you'll be, if red flags, you're directly referring the patient for endoscopy. Otherwise, lifestyle, weight loss, and trial for PPI. There are a few things like you can either test and treat or either treat the patient first. So you can start the medication like PPI for a month. If it gets better, you can stop the medication. But if he is 50% better and still 50% affected, then continue the medication for 2 months. Okay. And the counseling and separating, yeah. The last one is rectal bleeding.
Dr. Musarat,
Patient
what will be the red flag in this GERD?
vomit, blood in vomitus,
Mm-hmm.
and dysphagia.
Dysphagia
Okay,
and vomitus in the blood. Okay.
blood in vomitus, yeah. So rectal bleeding is the last case, and sometimes patient is mostly coming with the anal fissure symptoms. So, doctor, I'm getting blood from down below. When do you get it? Before the bowels, or mixed with the bowels, or after the bowels? Are your bowels painful? Is this fresh blood? And since when and how often does get? And along with that, ask for the constipation because hidden causes constipation. Even if you're giving him everything for the anal fissure and not treating the constipation, the patient might get recurrent. Okay. And sometimes excessive diarrhea can also cause. And yeah, this is the anal fissure. Other rectal bleeding can be chronic diseases like ulcerative colitis, and if there is dysentery, so you need to go through all of that. Like recent travel, you have gotten into some unboiled water from the stream, or what else? Yeah, associated factors will be like fever and weight loss and fatigue. Perineal symptoms will be itching and that pain on defecation. That will be the anal fissure. There could be the cases of hemorrhoids. So the history will be different, like how much blood is there. And every time you have a bleeding of, you have a history of bleeding, check for anemia signs. Patient is getting short of breath. Okay, so that is the red flag also. Risk factors is all obviously if there is a family history of cancers or IBD, then things will go like that. Examination is again pallor and weight loss or red flags, or weight loss is a red flag. And on examination, mostly whenever you're getting lower GI case, mostly in lower GI case, never forget DRE. Otherwise, if it's gastritis or GERD or acute coli um, or fatty liver, then still you can say that you can think of skipping DRE, but it's better no abdominal examination is completed without a DRE. Okay, and management will be again different for everything. If there are hemorrhoids, it's different. In conservative management, mostly topical and lifestyle. If it's anal fissure, then six bath is necessary. If it's ulcerative, then if you're not sure because you're not going to confirm, send them for the colonoscopy for the confirmation of ulcerative. And whenever there is chronic disease and you're going to start the lifelong medication, tell them I'm sending you for the confirmatory, and they might start you on medication. We call it DMARDs. Okay, but again, if she's a female, tell her that these medications might need